Now, as we go through this is really not intended to be a basic course. I'm going to make the assumption starting out that everybody has a decent knowledge of how to read EKGs. So if there's anybody here who's looking at this EKG, scratching their head thinking, I wonder what's going on, this is probably not the right room for you, all right? So we're going to skip over stuff like this. But I promise you also that the things that we talk about are not going to be esoteric, but they are things that you will come across in your real world practice. And these are things that you're going to know in order to save lives, all right? Just a few points. This is intended to be a workshop, so I invite people to make comments and to ask questions as we go through this. And take notes if you want. I think you have a PDF of all of the slides that you have access to, I believe. If not, or if you don't know how to access it, just step outside and ask Gail, because she has sent the PDF to everybody. And I encourage everybody to download the PDF after the course is over or during the course and review these slides over and over and over. In many ways, EKG is like dermatology in that what we find in real practice never looks like what they talk about in the books, right? And so you've got to see case after case after case to get good at this, and that's the way this workshop is set up. I'm going to show you a lot of cases of everything, but you still have to review this afterwards. And I encourage you to share these PDFs with your colleagues as well, all right? So first question, why is this important? Maybe I'm talking to the choir here. Well, ACS, which is what this session is all about, this is high risk. This is high risk stuff. And ACS to me is what true emergency medicine is all about, whereby if you make the diagnosis, there is a fantastic outcome in most cases, but if you miss the diagnosis, there can be a horrendous outcome. So oftentimes it's all or nothing, and largely it boils down to how well you do your history and your exam and how well you read the EKG. And as you know, in the United States, there's a tremendous med-mal concern that we all face amongst young people and older patients as well. Take a look at the statistic just to highlight how black or white this oftentimes is. Studies say that in the elderly, if you miss an elder patient showing up in your office or in the emergency department who's having ACS, if you inadvertently send them home, 50% will be dead within 3 days. So the burden really is on us to make the diagnosis right from the start. And then there's the medical legal profession, right? Johnny Cochran and all of his buddies out there. There's, just driving in from the airport, there's giant billboards for legal groups that focus on risk, on personal injury, in other words, malpractice. Here's a couple of websites that I pulled off the internet. Entire legal groups that are entirely focused on missed cases of acute coronary syndrome, or entirely focused just on going after cardiologists who get sued for this type of thing as well. In fact, missed ACS accounts for about a third of all the money we pay out. 20 to 30% of all the money we pay out in emergency medicine in malpractice is for missed ACS. In cardiologists, about 44% of all the money they pay out relates to ACS. For them, it's a bit more diagnosis, it's a bit more treatment, and a little bit less diagnosis, but all of us are at high risk. And a lot of these cases come down to misread ECGs. Now, I do a decent amount of med-mal consulting, and what I would tell you is, in the cases that I see, I would say probably at least a third, maybe as many of half of these cases will turn on the basis of a misread ECG. You can debate all you want about the history. The history is very subjective, right? Does crushing or pressure, is that really specific for ACS? Turns out it's not. What about nausea and vomiting? All these studies say that most of the history tends to be very nonspecific, with a couple of exceptions we'll talk about tomorrow. But when it comes down to the ECG, oftentimes this is objective information, and it's very difficult to argue when the lawyer blows up that ECG, and even a layperson on the jury who's only experienced in emergency medicine is watching the TV show, right? They can look at that ECG and say, oh yeah, even I can see a half or 3/4 millimeter ST depression in V2, 3, 4, 5, and 6. And we'll see that happen all the time. This is exactly what they do. And I'm not talking about subtle, non-specific stuff. I'm talking about the kind of cases where the physician or the PA or NP or the provider looks at the case later on and says, oh my God, I can't believe I missed that. All right? So we're not talking about subtleties. We're talking about things that are obvious, but oftentimes get overlooked and just simply missed. All right? So it's very important that we not miss cases of ACS, but also we're under the gun when we overcall cases of ACS. National databases have shown that about 10 to 15% of all cath lab activations result in negative caths, and a significant number actually get canceled by the cardiologist when they arrive and they take a look at the 12-lead ECG and say, I'm not even going to do the cath, this was overread. And the problem here is that every time you activate the cath lab and the entire team comes in and decide to cancel the case, there's a study from out of Boston that said that represents about a $14,000 loss. So the hospitals are really focused on this as well, and we all know that the cardiology folks get very upset when they get called in at 2 o'clock in the morning for a misread ECG. So there's a lot of pressure on us to not overread and also to not underread this. Bottom line is, whatever your practice is, you've got to know electrocardiography. And that's what this session is going to be all about. All right? So what we're going to do for the next couple of hours, before and after our break, we're just going to do cases. We're going to do case after case after case, and I'm going to try to show you a lot of examples, and I invite you to ask questions. I don't have all the answers. If I don't have an answer, maybe somebody else in the audience does. If not, then I will do my best to find the answer for you and get back to you. All right. Before we even get started, let me just take a quick survey. How many of you are practicing in emergency medicine? Raise your hands up high. So clearly the majority. What about office-based practice? Office-based? Family med, internal medicine? Family? Anesthesia? Okay. How many people do inpatient medicine? Just inpatient medicine? So a handful up there. And anything else? What else? Outpatient, inpatient, acute care, emergency medicine. Are there any surgeons here? One surgeon? Okay. Anesthesia? All right. Somebody said anesthesia. All right. And how many PAs and NPs are there here? All right. Great. Thank you all for coming. Any paramedics? All right. One. Great. All right. Excellent. So again, this is not intended to be so advanced that it's esoteric. I promise you, whatever your level of training is, if you consider yourself very experienced and expert, I promise you, you're going to get something out of this course also. And if you are relatively new, but you know the basics, hopefully, you're going to get a lot out of this as well. All right? All right. Well, let's go ahead and start with the case. All of these, by the way, are real cases. Some of these are ours. A lot are screw-ups. And my hope is that you will learn from our mistakes, all right? It's good to learn from your own mistakes, but I would say it's even better to learn from other people's mistakes, right? The first one wasn't a mistake, but it's a great case to start the show with. So this is a case that was sent to me by an emergency physician in India, Dr. Chanana. He was taking care of a 50-year-old man who came in with chest pain, retrosternal chest pain with diaphoresis, history of hypertension, and I'll save you the trouble of the rest of the story. Let's just say this is a pretty concerning story. All right, he's got some cardiac risk factors, and so he gets the 12-lead ECG. All right, here's the 12-lead. I'm going to blow up the relevant parts for you in just a moment. All right, so here's the 12-lead. The relevant parts of this are the inferior leads. All right, so and this was 11:22 p.m. The time's important, okay? There's no in-house cardiologist, and by the way, there's no cath lab here. So when they want to reperfuse a STEMI, they're using streptokinase. All right, which, by the way, thrombolytics are still the most common form of reperfusion worldwide. How many people here are using thrombolytics if you see a STEMI? Anyone? So a couple people, all right? So in the U.S., we've gotten very spoiled about cath everything, but worldwide, it's still a thrombolytic world, all right? So let's say you're working in his shoes, and your decision is, with this patient with a good story, does this ECG meet criteria to give this patient thrombolytics? All right? In other words, is this a STEMI? Now, there's no right or wrong answers here, and I know the coffee may still be soaking in a little bit, and maybe some people have central cord and can't raise their hand, but how many people would take a look at this 12-lead and you'd say, you know what, if I'm taking care of this patient, he's getting streptokinase? Raise your hand up. All right? How many people say, based on this 12-lead, no streptokinase? All right? How many people refuse to take care of him? So all the rest of the people, I didn't raise their hand. All right, fair enough. All right, that's fine. Okay. Well, let's take a look at lead 3. I think lead 3 is probably the most concerning ECG lead. Based on this lead, how many of you would say this meets STEMI criteria, assuming that it was only one lead that you need? How many of you feel that lead 3, based on lead 3, I'm giving lytics? All right, so a few more hands go up. How many of you say, no, it still doesn't meet lytic criteria? All right, and still a lot of people are off to lunch, not going to take care of this guy. All right, so you can argue about whether this meets cath criteria or not. Some people said yes, some people say no. There's a lot of uncertainty about this, which is absolutely fair. So what do you do? So I heard somebody say this earlier, get a repeat 12 lead, get serial ECGs. So move forward about 25 minutes at 11:46 p.m. Here's the repeat, and I'll blow the inferior leads up for you. All right, here's the inferior leads. Take a good close look at that. How many of you say now the repeat 12 lead? Based on this, yep, I'm going to go ahead and give lytics now. All right, so a lot more hands go up. How many say no, not yet? All right, so still some hands go up. All right, fair enough. All right, so what happens is, based on this repeat 12 lead, he decided to go ahead and give lytics, and this is a good story. Everything turned out fine. Shortly thereafter, the first troponin comes back, 56.96. I'm not sure what the units here are, but it's clearly elevated. Anytime a troponin is that high, it's got to be elevated regardless of the units, right? So they give streptokinase, and 9 months later, follow-up, the patient's doing well. So this is a good outcome. It was a good decision. Cardiology got consulted. They agreed with the decision. Troponins are positive. The patient pain improved. Everything went well. But it's a nice case to start with just to talk a little bit about ST segment elevation. Now, this was the first 12 lead that I showed you, and I even focused in on lead 3 and asked you, does lead 3 have ST segment elevation? Whoops. And I'll blow this up for you again. Is there ST segment elevation of, how much elevation are you looking for? A millimeter? What about up there? Where even do you measure the ST elevation? Is it down there, or is it up top there? I've got just a little bit of a coffee tremor here. Let's stabilize with 2 hands, all right? And then over here, gosh, is that ST segment elevation? So it's not that straightforward, is it? All right? So let's take a look at what probably is the definitive article on how to diagnose STEMI on 12-lead ECG. All right? This is the third intergalactic definition of myocardial infarction. Every 5 or 6 years, the European Society of Cardiology, ESC, the American College of Cardiology Foundation, the American Heart Association, and the World Health Federation get together and they publish the universal definition of myocardial infarction. So apparently when the Europeans and the Americans get together, they consider themselves the universe. So anyway, so the fourth universal definition, by the way, just got published a few months ago and essentially says the same thing. So they defined how we're supposed to diagnose STEMI, and here's what they say. First of all, where do you measure ST segment elevation? You measure it at the J point. So what is the J point? The J point is the end of the QRS. It's where the QRS turns into the ST segment. So that's where they want you to measure it. And that's an important point because when I was in residency, I was taught you measure it 40 milliseconds after the J point. Wrong. I still hear some people talk about that. And even some people say 60 milliseconds after the J point. Well, according to the universal definition, this is how it's defined around the entire world, even on Pluto, apparently. All right? This is how STEMI is supposed to be defined. You measure it at the J point, not 40 milliseconds later. All right? Now, the next question is, how much ST segment elevation do you need? 1 millimeter? 2 millimeters? When I was in residency, I learned 1 millimeter in 2 contiguous leads, and some of my attendings were saying, well, it's 1 millimeter in the limb leads and 2 millimeters in the precordial leads. It's not even that simple. All right? Here's what the universal definition says, and by the way, this is not the first time it's been defined this way. The prior universal definition said it this way as well. Notice this was published in 2012, so what I'm about to tell you is not new information, but it just hasn't gotten out there. It's 1 millimeter in 2 contiguous leads, except for V2 and V3, which changes based on gender and age. So in V2 and V3, if you're a woman, it's 1.5 millimeters. And if you're a man who's under 40, it's 2.5. And if you're a man who's over 40, it's 2.0 millimeters. How many of you knew this? How many of you were practicing with this definition? Yeah, this really hasn't gotten out there, even at the board review courses. And in the textbooks, people don't talk about this. But this is how it's supposed to be defined. You'll occasionally see it in some of the cardiology textbooks and some of the newer texts in emergency medicine. But this is the formal definition based on what in international collaboration of mostly cardiologists have gotten together for the past 10 years and been staying. And in the fourth universal definition, just recently published, same thing. In the US, ACC-AHA STEMI guidelines, same thing. Last time published in 2013. So this is how it's supposed to be defined. Now, I'm not telling you that if you see 1 millimeter in V2 and V3, just ignore it. That's not what I'm saying. There's other things that are important to look for as well. But the reason why they make this caveat in V2 and V3 is because of things like LVH and benign early repole, where you oftentimes will have a bit more ST elevation in V2 and V3. All right? So looking down here at lead V3, all right, it's changing topics a little bit. Is there anything else that is helpful in terms of telling whether somebody has a STEMI? Let's take a look at this impulse right there, that PQRS complex right there. If you look at the end of the QRS, if the end of the QRS is right on the isoelectric point. So there's no ST segment elevation in that complex right there. But is there anything else that can be helpful? Well, there's a Q wave. Q waves are great if you know that they're new, but I don't know that this is new. Maybe he's got previous Q waves. But what oftentimes can be, is anything else helpful? What do you guys think? Does that impulse right there, does that give you any concern? Any thoughts? It's a bit convex upwards, right? Normally I want to see concave like a cup holding water, all right? If it's straight or convex upwards like a tombstone, then you've got to worry about that. And so the morphology of the ST segment is incredibly important, and we're going to really, really hammer that home as we go through this as well, the morphology. When you see straightening on the initial part of the ST segment, if it's tombstone, I don't think anybody misses that. If it's convex upwards, nobody misses that. But when it's straight, your computer will miss that, and oftentimes the physicians will miss that as well, but you can't afford to. All right? The initial part of the ST segment should never be straight. If you look at this impulse right there, if you look at this right there, that's nice and concave upwards. You see how it's like a cup holding water, slightly concave upwards. But this, and that's concave upwards also, this impulse right there is too straight, and that's a bit too straight as well. So when you see impulses that look like that, you've got to worry that you're looking at cardiac ischemia. And so what do? You're not going to activate the cath lab simply based on that morphology, but you need to get a repeat 12-lead ECG. And if there's only one thing that you take home from the entire session today, all right, I'll be just kind of disappointed with that. But if there's only one thing, please let it be serial ECGs are critically important. All right? So reciprocal changes as well. Did you notice that there was some ST depression in AVL? And we're going to spend some time talking about AVL. It's one of what I call the Rodney Dangerfield leads, right? Remember Rodney Dangerfield, famous comedian? What was Rodney Dangerfield's famous line? I get no respect, right? Get no respect. Well, if Rodney Dangerfield were a lead on the 12 lead, what leads would he be? AVR and AVL. We'll talk about both of them, how important they can be when you're evaluating possible ischemia. And in the presence of an inferior STEMI, AVL is incredibly important. AVL can oftentimes give you the first indication that your patient is in the throes of an impending inferior wall STEMI. All right? And then the morphology as well. Those are normal T waves. When you see the beginning part becoming very straight, you've got to worry about early cardiac ischemia. All right? And again, get serial ECGs. That was the second ECG. Notice how much easier it became. Now there's no doubt that ST elevation has developed, and it's simply by repeating the 12 lead 20, 25 minutes later. All right? And remember, what is this 12 lead? It's not like you're repeating a CAT scan, all right, which is expensive if you do that, all right? It's not like repeating even a lab test, which isn't expensive, but oftentimes it takes a long time. Repeat the 12 lead ECG. It's a piece of paper. And it can give you life-saving information, and you can do it 10 minutes later, 30 minutes later, an hour later, piece of cake. All right? So take-home points from case number one. First of all, let's accept ST elevation is complicated. All right? It's not just a simple 1 millimeter the way it's always taught. All All right? There's more to it than that. What else can help? Looking for reciprocal changes can be enormously helpful. Looking for the morphology of the ST segment can be enormously helpful. And getting serial ECGs. And then the other point I'll make is whenever you have any concerns or doubts, just consult either a senior colleague, somebody else to take a look, consult cardiology. You should never have to apologize for having somebody else take a look at that also. Because sometimes someone else's eyes will pick up something that maybe you missed. All right? All right. Questions? Questions about case number 1. So I like collecting signs. So people send me signs from all over the place. I think this is from Seattle. But I use these as little mental breaks here. Everyone's okay with case number 1? All right. And we should have this in every city, right? Drive carefully. We have 2 cemeteries and no hospital. All right. Case number 2. Case number 2 is a 48-year-old man who comes in with atypical chest pain, and all of the rooms are occupied. We all work in scenarios like this, so we're using the hallways, except when the Joint Commission shows up, right? So, but JC's not there, so we're using the hallways here. We'll have to edit that off the video. All right, so we're using the hallway while we're waiting for a room to open up, and they get a 12 lead in the hallway, right? And here's the initial 12 lead. And this is while the patient's having some pain. He's not dripping sweat, he's not clutching his chest, he's just having some persistent pain, but it's not knocking your socks off. You get a 12 lead, and here's what you see. Any concerns about this 12 lead?